We're at the top of
All right,
the
we'll get
hour.
this
Want
thing
to give a couple
started.
minutes or get started?
We can go ahead and get started. Everybody's good?
Absolutely. So,
All right. So welcome. Hello, everyone out there. Welcome to today's call. Appreciate you for being on. Just want to say, thank you for being on. I want to say thank you to our providers who jumped on here with us today. Also want to say thank you to the folks who organized Tech Sergeant Mariah McKay at the AFRS level, Tech Sergeant Ronaldo Perez Santiago, 342 RCS, Tech Sergeant Corey O'Shea, 342 RCS, Tech Sergeant Joseph Zito, 332 RCS, and Staff Sergeant Megan Powell, 347 RCS. Just want to say thank you guys again for coming together to make this thing happen. So we have two moderators today, Tech Sergeant O'Shea and Tech Sergeant Perez Santiago. I'm getting ready to turn it over to them here in a second. Please, if you have any questions, throw them in the chat. We will get to those at the end. Mute your mics, but if you need us to call on you sooner than later, just hit that little raise hand button and we'll go from there. All right, so Sergeant Perez Santiago, sir, I will go ahead and throw it over to you. You can take it away.
absolutely, sir. Thank you very much. So my name is Tech Sergeant Ronaldo Perez Santiago. I am the Officer Accessions Recruiter out here in beautiful Guaynabo, Puerto Rico, representing the 342nd Recruiting Squadron. And what we have for you today is a mental health panel. It's very important, obviously, because especially in the times that we're living in right now with COVID-19, the pandemic, which is still not over, even though things are getting better, with so many things around the world, with things you may be dealing with stress, anxiety, depression. Obviously, work is a complete roller coaster. So many things that happen, right, that just affect our mental health. Well, today we have in store for you three professionals that are going to speak a little bit more about that, on ways to deal with it, and just give out there some really, really good information that really is necessary for everybody. And maybe you're not dealing with anything, but maybe there's somebody that you may know that's dealing with stuff as well. So we're just here to give out some really good information and hear from the professionals themselves. So without further ado, I'm gonna transition over to Sergeant O'Shea, talk a little bit about that.
Yes, sir. Thank you so much for kind of getting us started here. And, there's a couple of things that I'm going to talk about. First and foremost was a kind of one of the whys behind, what material we decided to talk about today. And we're fortunate to have Chief Master Sergeant Goldstrom provide us with some information as far as a recent survey that was, or not a survey, but a team of MFLACs that they went into a contract with that provided MFLAC services for our entire 3,500 plus members of our recruiting community. And they have released some of the preliminary findings of that particular initiative. And so we're not really going to get into any of the specifics about that survey, but trying to stick to some of the heavy hitter items that were discussed as far as the topics that individuals were reaching out for support for without discussing any specific type of support. It could have been something as simple as, picking up the phone and calling an MFLAC or an MFLAC team going out to an annual or a semi-annual or quarterly training just to talk about the services that they were going to provide. And the top common reasons for individuals reaching out for services fell into a couple different categories, specifically military life. That could be dealing with PCSs, relationships with supervision, coworkers, applicants, the work environment. Another category was adult relationships that could mean one of 100 different things, general life skills, maybe on the personal side of the house, outside of the uniform, as well as child and youth relationships. I'm assuming that category probably was a little bit more specific to, service members and their children, maybe dealing with issues on that front. And so to kind of provide our recruiting service with a couple of tools for our tool belt as we not only recruit the next generation of airmen, but also conduct our own personal and professional lives, but also in positions where we might have individuals that need our support. We've brought together 3 mental health providers from a couple different spectrums to kind of discuss some individual things from their angle as far as what they can see to kind of provide some support. And so we're going to start off with Captain Galvin. He is at the present moment a Nurse Corps HPSP candidate. What that is the Nurse Corps Health Profession Scholarship Program. He was selected, I believe, a couple years ago as a psychiatric mental health practitioner. Before I came into this profession, I had no idea that you could be a doctor within the nursing field, but it's true, you can. And he's a living example of that fact. So we'll go ahead and pass it over to him to kind of give a little bit of his bio.
Well, hello, everybody. First of all, thank you so much for having me here. I'm very grateful to the Air Force. Prior Navy, I was in the reserves in the Navy from 2014. And in 2019, I was given the opportunity to further my education and become a psychiatric nurse practitioner in a doctoral program, which I finished. So I'm no longer a candidate for the HPSP. I'm a product of the HPSP program, which I will now be serving in the Air Force. I'll be PCSing in 2 weeks, be at Luke Air Force Base in Arizona. And I cannot wait to pay back the support that the Air Force has given me thus far. Personally, I am a psychiatric nurse by trade. I've been a nurse since 2010. I've always worked in psychiatry, particularly. I've done things like staff psychiatric nurse in multiple VAs, stretching from Illinois to California. I've managed mental health units in the civilian side, also in the federal side. And working with the VA population and being in the Navy, I wanted to do more. I wanted to be able to help this community, and that's a big reason why I pursued my psychiatric nurse practitioner degree. And I'm looking forward to payback, and hopefully today I'm able to give you guys some information that can definitely present helpful in the future related to mental health. So thank you so much for having me, and looking forward to paying back to the Air Force the things that they've done for me.
Good afternoon. I'm Keith Boronsky. I'm originally from El Paso, Texas, and my only experience in being in the military was a year in high school ROTC. That was before women were allowed in combat roles. We were performing drill team. And we had scholarship opportunities in a few selected medical fields. Many times I've wished I had gone that route. I passed up that opportunity and said yes to marriage, and I became a military spouse. We PCSed at least 5 times along with children and pets to bases in North Carolina, Florida, and Okinawa. At 34, with kids in school and settled in our final duty station, I rode my bicycle to the local community college, taking the first step towards completing my associate's master's and finally a master's degree in social work. After 20 years as a dependent spouse, at the age of 40, I began work as a clinical social worker in a psychiatric hospital and as a therapist in private practice. I've worked with Air Force individuals and families for 32 years. 14 of those years are in Air Force family advocacy. Currently, I'm in my 6th year as treatment manager assigned to Spangdahlem Air Base, Germany. And thank you, Tech Sergeant O'Shea, for the invitation to be part of this panel. And I'm going to pass to Captain Johnson.
Good afternoon. Thank you, Ms. Keith. I really appreciate that. So I'm Captain Johnson. I'm a licensed clinical psychologist at Robins Air Force Base in Warner Robins, Georgia. I guess background wise, education, I completed my bachelor's at Vanderbilt University in Nashville, Tennessee, and then went on to do my master's degree in human development and psychology at Harvard University in Cambridge, Massachusetts. So then I took a pause on school for a little bit and did research, which is a pretty common path, and then started my PhD in clinical psychology at Drexel University in Philly. After about a year and a half in my doctoral program, that's when I realized I wanted to pursue active duty service. And that really prompted me to find a health professions recruiter, like one of the many of you possibly on this call, and pursue the Health Professions Scholarship Program, or HPSP. So I commissioned in 2018 as a second lieutenant as a part of that program, went back to school, completed my my academic studies. And then from there, I started my active duty service in June 2020, when I promoted to captain and went to officer training school right at the start of the pandemic. So that was kind of an interesting, a unique experience. From there, I PCS to join Base Andrews, where I completed my residency training for 1 year. And then I PCS to Robins Air Force Base in September of 2021. I became licensed as a psychologist in October, and I've been a staff psychologist in the mental health clinic at Robins Air Force Base for about 8 months now. Primarily what I do as a psychologist in the mental health clinic focuses on assessment, diagnosis, treatment of mental health related concerns. So I definitely treat, major depressive disorder, PTSD, social anxiety disorder, things of that nature, but also deal with a lot of individuals that are presenting for relationship or marital stress, or difficulty coping with work or loneliness or grief. So really a lot of issues that impact your mental health. Other parts of my job really just focus on command consultation with other medical providers, outreach briefings, case management, a lot of different kind of hats to wear. But that kind of encompasses a lot of what I do, which I'm sure we're going to talk more about with the other providers on this call. But with that said, I'd like to jump into a brief actually that I'm just going to share some kind of tips and tricks to start us off right and hopefully get us energized for the rest of the panel. So if someone could just cue my slides, then we can get going. All right, perfect. All right, so for today, what I wanted to do is just talk about how we take action to combat stress. So I'm going to talk about the ways that we can shift our perspective to increase that motivation for taking action. And then I want to prepare and present some very specific strategies that you can kind of take with you to help reduce the impact of stress. Just a heads up, I do get tired of hearing myself talk. So I'd love for people to chime in, or, if there's some questions or, some comments that get thrown in the chat, I would love to hear from people. Don't feel like you're interrupting me. I definitely would like to hear from you. So you can go ahead and go to the next slide. So I don't like a lot of words on my slides, so you'll come to find that out, that I have like a lot of pictures and memes. But I think definitely a lot of us can identify with some or maybe all of these pictures. So for me, the first picture on the left there really exemplifies when we have a lot of stressors, but we really have no awareness of what's going on, or maybe we just are refusing to address it, right? The stress has gotten out of control. We're not doing well, but basically we're not concerned about it, but we're not in a good place. The middle picture is more of kind of denial. And then, bam, we realize it is a problem. We are freaking out, but things have been on fire for a while. And then that third picture, we're really trying to put the fire out. But we're realizing to ourselves, how do we let it get this long? How do we allow it to be this way for so long? And at that point, we're really being reactive, but kind of after the fact. Next slide. So in all those scenarios that we just talked about or we looked at, we were very passive, and we waited too late to become active. And so then it kind of created some challenges. So the idea of talking through some of the things that we're going to talk through today is really to shift our perspective, right? We really have to consider, how do we shift and place ourselves in more of an active mindset, and how do we put that into practice? Next slide. So I think a lot of us maybe have been victim to this mindset before this, I'll be happy when. I'll be happy when the pandemic's over, or I'll be happy when the kids go back to school, or I'll be happy. And, if you want to drop some of your I'll be happies in the chat, then you can go ahead and do that as well. But the idea there is that that's a very passive approach, right? So we're not really taking an active stance. We're waiting for our conditions to change. Next slide. So what I found is that the author of The Happiness Advantage, which is an advocate of positive psychology, this is something that he said. So, if I know everything about your external world, I can only predict 10% of your long-term happiness. 90% of your long-term happiness is not predicted by the external world, but by the way your brain processes the world. And if we change our formula for happiness, we can change the way that we then affect reality. And so really what that means to me, and what I kind of take away from that, is that oftentimes we're waiting for those external factors to determine our happiness. And similarly, we often rely on circumstances to change or decrease the amount of stress that we have. And so like with happiness and with stress, this approach doesn't really cut it. Like oftentimes it can be beneficial if we decide to take action rather than waiting for our circumstances to change. And oftentimes, if we're waiting and saying, okay, I'm going to wait for the perfect conditions not to be stressed, we're really setting ourselves up for failure. So what I want to talk about is really just what are the ways that we can change our mentality or change our formula for managing stress. Next slide. So the idea is just to get rid of this mentality, this passive approach. And next slide. Put ourselves in hot pursuit, right? Hot pursuit of managing stress. So if we're not currently that stressed, it's a good time to build those healthy habits so that when we are stressed out later on, we've already kind of built that muscle memory. And then if we are really stressed at that time, that we start engaging in behaviors that help us manage that a lot better so that we don't become even more so overwhelmed. Next slide. So what I want to do is just talk about two different areas that I think are very valuable when we talk about stress. So that would be healthy habits and enhancing the positive. And I just want to briefly touch on both of those and share some very specific tips and tricks that I think will be beneficial to those that are watching this call if they don't already know about these things. Next slide. Next slide. Am I frozen or is the...
No, ma'am, you're not frozen.
Okay, I think the slides just went down.
I apologize for that.
It's okay. Flexibility is the key to air power and all that. There we go. Wonderful. Okay, so healthy habits. So when it comes to healthy eating, fitness, sleep, a lot of health behaviors, those often fall off a lot of the time when we're stressed. And there's just really so much research linking healthy behaviors to better outcomes when it comes to managing stress, really enhancing your mood. So I want to pass along just 3 tools that I have that I hope people can find helpful and kind of implement and take away from this call. Next slide. So the first is called habit stacking. So James Clear, who wrote Atomic Habits, which is an excellent book, talked about habit stacking with, starting with a habit that you already have and then adding on one that you're trying to create or we're trying to build. So after current habit, I will new habit. So next slide. So an example is, after I brush my teeth, I will do 10 push-ups. So the idea is like, hopefully all of us are brushing our teeth at least once a day. I mean, better yet, 3, right? I don't know. I have some dentist friends that might provide better information, but if you're in the morning waking up and brushing your teeth, then you're automatically, after you put your toothbrush down, going and doing 10 push-ups, right? So allowing yourself to have an automatic cue for a new behavior when you're stacking it with one that you do fairly frequently. Next slide. The next one talks about habit stacking plus temptation bundling, right? So this works on the premise of reinforcement. So as we increase the likelihood, if we want to increase the likelihood of doing something, likely what happens to be increased is when you have some pleasure, some benefit that follows. So again, you're using the first part, after current habit, I will new habit. And then after that habit, you're giving yourself a reward. So in this example, you're doing those 10 push-ups, but after those 10 push-ups, you get to go on social media for 15 minutes, right? And hopefully set a timer so that you don't stay on for an hour. Next slide. So the third trick is just really focused on the 2-minute rule. I often work with a lot of people that kind of bite off more than they can chew. I know that I've done that and oftentimes had that all or none mentality. So if I decide I want to go to the gym and I stay late at work, and then it's almost like if I go, I'll only have 30 minutes. Sometimes even that can just say, well, I better not bother, right? So that kind of all or none. And also when people are starting to get a new habit and put it in place, we can oftentimes choose something that's really hard to do. And when we can't do it, we fall off. So the 2-minute rule really protects against that. So nearly any habit that you're trying to build can really be kind of broken down into 2 minutes. So if you look at the top one, going from very easy to very hard, just put on the shoes and take them off and go back to your day and do that for a week. And then from there, once you put them on, then maybe go outside and walk for 15 minutes and really progressively showing that, going from something that's so easy, anyone can do, to getting to that really hard goal that you have down the line. So next slide. So those are 3 just healthy habit building tools that hopefully can kind of be implemented, or you can try them in the next coming weeks to see if that's something that helps you kind of build those habits or even maintain the ones that you've started. The next piece I want to talk about really quickly is enhancing the positive, right? And so when we talk about positive emotions, it's really powerful that we have, on an hourly, daily, weekly basis, that opportunity to enhance that. Oftentimes when we're really stressed, it's a huge deficit. We spend a lot of our emotion time anxious, angry, sad. So it's really important for us to find ways to shift that balance and shift into more of a positive mood state. So next slide. The idea or the question becomes like, can we cue a positive emotion? Like, is that possible? Like, are we able to do that? And so I wanted to have an opportunity to practice here and see if we could. Next slide. So as we look at this slide, I wonder if anyone is feeling just a little bit happier, a little bit like of a positive emotion, looking at any of these pictures. And if you're not, then don't share, because we're going to think, oh my God, how could this person not like these beautiful animals? But you start to realize like, wow, I just shifted from wherever I was, or even if I was mad or upset or whatever, into a neutral space when looking at these pictures. Next slide. And if you're wondering who this lovely, beautiful cat is in the middle, that is Tilly, and she's wonderful, of course. Okay, I've got some smiles happening. So the idea here is with savoring, we want to not only cue those positive emotions, but we want to present an opportunity for them to stick around. So with savoring, the idea is that we're attending to or appreciating and enhancing positive experiences that occur in our lives. And the way that we're doing that is we're actively triggering it, and then we're spending a few hours or moments or whatever time frame we design to kind of benefit from that feeling, that positive emotion that we just cued. Next slide. So what I want to leave you guys with is this practice, and it was described in Dr. Seligman's book, Flourish. And my hope is that in the upcoming week, it's something that you might attempt at least once a day, right? So at the end of the day, what you do is you write down one thing that went well, and then you briefly write why it went well. And so this has been shown to cultivate that gratitude, increase your optimism, boost happiness, but it also kind of goes hand in hand with self-esteem, right? So when you write about what went well, oftentimes we're involved in that. We've done something to make it go well. So it can also boost your self-esteem. On the other side of that, you can also look at doing it yourself, but how you do it as a shared practice. So I've talked to people about doing it with their spouse at the end of the day, or making it a ritual at dinner time with your children, and starting to build those skills and, stress management tools, even in your kids from a young age. Right. So this is a practice that I hope that, you'll try, you'll see, and you take some time at the end of your day to savor that positive emotion that comes up from what you did well. Next slide. So this final slide are just 3 amazing book recommendations. When people are trying to start healthy habits and they're trying to build those really important health habits that they want, these are some books that can be beneficial. So I talked about some of the strategies earlier in the health portion of this that came from Atomic Habits. And then you also have those 2 other books if you're looking for any recommendations. But that's it for me. That concludes the brief portion. And I hope we can kind of jump into the panel and get any questions answered and have all the 2 other wonderful presenters share their experiences.
Okay, so I learned a lot from that. Thank you. I appreciate that. In the introduction to the form, you recall that military family life counselors have helped people in the areas of military life, child, youth, and adult relationships, and in general life skills. So I thought I'd touch a little bit on some people that I've worked with and keeping their privacy, of course. So their real names or personal information will not be mentioned. And then I'll do some specifics. So there's reasons that people come to our program. I mentioned that I work with family advocacy. This is not an infomercial, I assure you, because most of our services provide similar services for the same problems to lots of similar people, mostly airmen and their families. So most of the problems that were identified are also those that we see. I'm going to emphasize the importance of self-care and provide examples of situations. I'll mention that clients that are expecting or have children under the age of 3 can call our office and receive services, including pregnancy, parenting, and marital counseling in our new parent support program. Those that do not have kids under the age of 3, not expecting, they can voluntarily call and they ask for individual, family, or couples therapy. Like I said, those programs are voluntary. We're not going to reach out to a command. We're not going to call anybody about you. Even your mama can't get your information without your written permission. Our third program serves individuals who did not ask for help. Many have told me their first appointment when they were kind of voluntold or escorted to our waiting room that they had been talking about seeking services and didn't get around to it until they ended up in a maltreatment situation or an alcohol-related maltreatment situation. Our referrals come from lots of places, in addition to self-referrals. For the maltreatment, it could be anybody who cares or is concerned that there's, something dangerous going on. One component is the military life component. People are arriving, and you already know that. You've all PCS or you've had to make changes, but our clients are people that are arriving or departing, adjusting to life in a new location. They've said goodbye to their family and friends. They're trying to secure childcare or get kids adjusted to a new school. All of this is stressful. The active duty member is balancing his or her personal needs with duty requirements. They hope for promotion, you hope for promotion, protecting your career, and meeting the needs of spouse and children. Often enrolled in college programs or additional training on top of everything else they're balancing. And like I said, you know that from your own experiences. One time I was waiting to speak to a group of extremely jet-lagged newcomers. They were barely making it through the day with briefs that are required to obtain overseas driver's licenses, transportations, and housing. I caught an airman's side of a phone conversation with his wife. He had stepped out to take the call. And I wish I could even show his demeanor, but he looked like you could have blown him away with a feather. I wanted to come and put a pillow next to the wall so he could lean into it. But his side of the call said, "I'm sorry, babe. I wish I could come take you to get a sandwich. I can't leave and I don't have a way to get there." He looked so tired and overwhelmed. You may have had this experience. I think that's the first time that I realized what it's really like, being a dependent spouse. I don't think I considered all of the stress of the active duty member, and that his expression just said it all. I'm going to go into another story of a couple. This was a dual military couple with 4 children that came to my office seeking marital therapy. The husband had just returned from a 6-month deployment to Iraq, and they were having trouble readjusting. The active duty wife left behind had to balance responsibilities normally managed by both parents. Also had to cope with demands of rotating shifts and several recalls. The husband returned from a war zone, but the wife was the one suffering PTSD. In a few visits, the couple learned the importance of active listening, needed to support each other and have their own needs and feelings heard. They did not have to give advice. They didn't have to rescue the other person from their experiences. They didn't have to compete for who experienced the most stress. They learned to listen with empathy and sympathy, a few minutes at a time, and ensure each adult had individual time to attend to rest and healthy activities, and take time to spend positive time with the kids. The children also suffered during their father's absence and sometimes tried to get attention by acting out. By taking care of individual needs first, spending time with each other, the couple second, the adults were able to enjoy their family and work as a team to attend to the children's varying needs. Sometimes parents can't work it out and children just won't respond to positive parenting. That's the time to reach out to parenting programs, counseling with chaplains, MFLACs, family advocacy. Also good information online at Military OneSource or other resources. Those of you who have children or teenagers may have noticed that there's usually no 2 kids alike. And also the idea of being in agreement when raising children is sometimes difficult or even a myth. One parent might be authoritarian, my way or the highway, while the other parent might be democratic. Children have a say. Or laissez-faire. Don't worry, they'll figure it out. Money, children, and family back home can be areas of conflict, but jealousy at the heart of many problems is at the heart of many problems leading to the need for help. Jealousy and mistrust, believe it or not, including things like text messages, activities, coworkers and friends, and gaming. Almost anything that leaves the other person out can cause jealousy. Also, the use of substances like alcohol, tobacco, or vaping. Now, you think I'm going to tell you have to give all this stuff up, right? Absolutely not. You do not give up everything you enjoy, but you stop for a minute and listen to what it means to the other person. What it means is that you listen, truly listen to the other person's concerns without being defensive. Take time uninterrupted by calls, texts, TV, just for a few minutes. Put the phones down. Turn off the phones even. Move away from the TV. Wait until a good time when the kids are occupied. Make eye contact. Let the other person know that they have your undivided attention. Now, I know you all have really, really busy lives, but one thing that happens is that so many, I guess, stresses arrive when you're balancing your particular work in a day, your finances, the demands that are imposed upon you by other people in your life. Sometimes there's nothing you can change in your life, or it seems that way. So what's the one thing that people try to change? Their marital status. Everything flows downhill and the marriage starts suffering. You run out of time and energy for each other, and it seems really, really hopeless. that may be the time when you would need to pick up the phone and call someone, chaplain or any of the helping agencies mentioned above. The last situation I'd like to tell you about is a success story, and it involves an active duty husband with a child under the age of 3 and a wife who was abusing alcohol. The husband called, of course, concerned about consequences to his career if he sought help, wanted to make sure he could come into a voluntary program so nobody would have to know that the family's having difficulties. They came in for their parent support appointment since they have a child that's under the age of 3, but the wife refused help. They spent the session blaming each other and justifying their opposing positions. Several months later, we received a call about a 4-year-old going to the neighbor's house to get help to wake up her mother. Police were called, command notified, and the wife received a referral to the drug and alcohol program. And of course, family advocacy. She was angry, she was defensive, and she was resistant. She was embarrassed that we were in her business. Her husband was embarrassed as well. Now, the command knew about the problems in his family, but he was surprised at how much support the command provided. It actually took a second similar incident a few months later to get the wife's attention, to help her to see that it wasn't everybody else, that she really had a serious problem. She saw how her drinking was affecting her marriage, her health, and her relationship with her daughter. The reality of what could have happened to her daughter wandering around while she was passed out really was her wake-up call. She got serious about recovery. While her daughter was in school, mom started walking and then running every day, added a weekly yoga class and more time with friends. She went to Alcoholics Anonymous 2 to 3 times a week, and she got a sponsor. She came to individual therapy weekly. Within a month, she told me about how much she hated me when she first met me, but she also looked about 10 years younger. It was really amazing at the changes she had made. Last week, she found me on Facebook. I'm going to tell you, the clients are really, really respectful. I might get one person reach out once after I've stopped seeing them. And usually it's to tell me that, that they're still doing well or some changes they've made. But I heard from her. Since they PCS'd a year ago, she has been sober for 18 months. She's run 2 marathons. She still walks or runs 5 days a week and has gotten 2 promotions in her job. She reports a close relationship with her child and her husband and her daughter, and can't believe she almost lost everything that was dear to her. Her husband was also promoted, and they're now making retirement plans within the next couple of years. Conclusion for me, my part of this, I've enjoyed working with so many individuals and families through a variety of personal and relationship problems. The reward is seeing happy and healthy individuals, essential components in healthy relationships. I'm delighted to have been part of their success stories, but the credit goes to the ones who have become brave enough to recognize and seek help. It takes a lot to make that first call. I know things have improved when I try to close out their maltreatment cases, and they ask if they can please continue since things are going so well for them. I'm going to turn that over to the next presenter, Dr. Galvin.
Thank you so much, Ms. Keith. First of all, I just want to thank Captain Johnson and Ms. Keith. I think mental health has such a so many sides that are very, very important. And I think that's been illustrated by my previous speakers. So I wanted to take a little bit of a shift. And I want everybody to come with me in this journey of imagination. I want you to think about someone that has an issue with diabetes. You go to your primary care provider and they say, hey, you have diabetes and you're gonna have to start taking some insulin, right? And you get home and your wife asks you, oh, so what the doctor say? You're gonna tell them, oh, I was diagnosed with diabetes and I'm gonna have to take insulin. You go with the guys to play basketball on Sunday and then they tell you, hey, what happened to that appointment you had the other day? And you're gonna say, oh, they diagnosed me with diabetes. I guess I'm just gonna have to use insulin from now on. And so that's just what's gonna happen. Now, take a second and think about what would it be like if instead of diabetes, that person would have been diagnosed with anxiety, depression, PTSD, any of those mental health conditions that are so prevalent in our military. Do you think that that person would be so open to talk about those issues? Do you think that that person would be so comfortable enough to talk to their friends about this sort of situation? What do you guys think? I want to hear from somebody. We haven't heard from you guys. We're not just here to talk. We're here to listen. So please, somebody share your thoughts on that.
Yeah, I think a lot of people are willing to, do that. They keep it to themselves.
Okay, very good. Thank you so much. Anyone else?
Yeah, so from my angle, I can kind of see how, putting on the military uniform and having that, tough, appearance would, kind of be a deterrent for somebody to want to, expose a weakness that they might have, so depending on the environment that they're in, or who they trust, I could definitely see somebody being hesitant.
Absolutely. There's a reason why we're not talking about hypertension today, right? There's a reason why we're not talking about diabetes today, right? Those are things that are happening in the military, and it happens in exponential rates. But there's a reason why we're not talking about those things today. We're talking about mental health because the biggest issue that we have with mental health is the fact that people are just not getting treatment early enough. People are fighting against the admission that you might need some help, and that is making matters much worse than they can. My job in the military and in the civilian world is I assess patients. I try to figure it out if I can put a name to it, meaning diagnosing something, and then trying to figure it out, is there some sort of medication that can help you with your symptomology that can improve your quality of life? One of the biggest fears that military members have is that we may prescribe them with a medication that would force them out of the military. It is a real fear. It is reasonable. It's logical. However, the reason why I really wanted to be a part of this panel today is because as a mental health provider and as a prescriber, my first and foremost importance is the mission. And the mission is to keep you here, keep you well, and make sure that you are performing at your best potential. And a lot of times we have so many tools that we can utilize to help the patient deal with their symptoms in a way that it does not affect their military career. But a lot of times that gets pushed off to the side until it's too late. There's a crisis, an event has already happened that we can't just take back. Oftentimes, we have the tools to manage those situations effectively if we could possibly get to those members early enough. And I think that everybody here can agree that our mission today is to provide you with resources, to know that we are on your side, and that our job is to make sure that you're doing well so that you can be the best member in the military that you can be. There's a lot of medications that are not for mental health conditions that are used for mental health conditions. Things like blood pressure medication that can help you with anxiety. Things like antihistamines, medication for allergies that can help you with sleep, right? So there's so many tools that we have in our arsenal. The only thing that I beg my members for is I want the opportunity to try to figure it out. I am begging them, give me the opportunity to try to figure out a plan that I can help you with your symptoms, address them early enough so that it doesn't become a crisis. Oftentimes, you will have a very difficult issue talking to Captain Johnson and Ms. Keith about your issues because it makes you too anxious, right? So talk to me. I can figure it out if I can give you something to prepare you to attend those sessions, and so that you can learn, you can acquire those skills, and maybe shortly down the line, I can take that medication away because you've acquired those skills. You're better equipped to deal with your situation, and your symptomology has just gotten better. So again, I'm going to continue to do the same thing. I'm begging everybody to please give us an opportunity to help you. Give us an opportunity to get in early enough to be a part of your journey and make sure that you are the best member that you can be in the military. Whether it even involves medication, psychotherapy, whatever it is, we're here to serve. We're here to serve, and we want everybody to be doing well mentally. And that's really what our job is. So that's really the message that I wanted to convey. And I will continue to beg you guys to ask me questions if you have any. Thank you so much for having me here.
Yeah.
Yes, sir. Yeah, thank you very much, Dr. Galvin. That was definitely very informative. In this portion of the panel, we're going to be asking a couple of questions. I don't see any questions at the moment in the chat, but I did have one myself, to be quite honest. And this is for all the professionals, by the way. I know you spoke on it a little bit, Dr. Galvin, but could you guys talk a little bit about the misconception that, if you seek help for mental health purposes and stuff like that, like it's going to affect your career? Like, can you guys touch on that a little bit? And this is for everybody.
I think Captain Johnson is in the military right now, so I think she'll be a better asset of this question. What do you think, Captain?
Sure. So I think over the past couple of years, leaders have done a really good job of starting to pass that information down to their troops and present to them this idea that, your career isn't going to be negatively impacted in the most cases if you come to mental health. I think what Dr. Galvin said is really important, is that oftentimes when people's careers are impacted, it's when they come into mental health and it's so late that they're already in crisis, that they're either suicidal or they have a very significant mental health disorder that's going to require them to take a knee to receive treatment to then get back on mission. So I think one thing that we can emphasize is that the people that come in early, that come in when the stress is just starting, or they're noticing that they're not able to cope, that's the best moment for you to engage in treatment and to start to deal with some of those challenges, so it doesn't get to the point where it impacts your career. So I think as all of us as providers have seen cases where they're coming in so late and they talk about how long they've been struggling and suffering, and you just say, hey man, I wish you would have, come here 3 months ago, 6 months ago.
All the time. Oh my
right.
God. Yeah.
And so really just kind of reiterating to members, reiterating to command teams, reiterating kind of broadly to all the providers and everyone else that has those touch points, that there's an opportunity for you to receive care and for it to have no negative impact on your career. But the earliest you come in to see us, the earlier you come in to see us, the more likely the case is that you're not going to have any career impact, and that you're going to be really well primed to be back on mission faster in fit, fight, shape and form, and that you're going to have that opportunity to do your job even better because now you have coping skills that can enhance your ability to do the mission and live in your life and have that better quality of life.
Thank you, Captain Johnson. If I can add a little bit more to that also. She talked about the coping skills, and she talked about the help that you need early on, but I've seen situations when I was in the Navy where a person was dealing with insomnia. They were having a very difficult time with sleep. And they let that go on for an extended period of time, to the point that the person became mentally ill because of a chronic issue with insomnia. Well, the person ended up having a breakdown. They went into a crisis. And then because of the crisis, there were some consequences, and the person's career were definitely negatively impacted. However, if those things that like insomnia, anxiety, and sadness, if we deal with those things early on, there's a plethora of options that we have that will not affect the member's career at all. And if anything, it can prevent issues in the future. And so that's really the biggest message that we're trying to get out to all of our members.
So I have a couple of questions, and they just to kind of summarize this, I feel like I've got a much better understanding about, the different corners of the, mental health spectrum. And, in my, earlier years of my career and even entering into the Air Force, I didn't truly realize how many different specialties there were, within the mental health realm. And so I have a couple of questions here for each of you, and we'll start with Dr. Galvin. So
Mhm.
if somebody wanted to, speak with you directly, do they have to go through a referral process to be able to get FaceTime with a psychiatric mental health nurse?
Not necessarily. They can request to mental health assessment. They don't come to me directly. We do have techs and nurses that do the evaluation, the early evaluation, and then they within the mental health um, group or with the mental health providers, then we eventually get to see them. But they don't have to get referred by let's say a primary care provider or a different specialist.
Yeah.
It's normally the case. That's usually how it is. They go to to a different provider, and the provider looks at them and say, you probably can use some help in that sense, which in terms it means it's a little late, but no, they don't have to.
So then would they go through family advocacy and kind of, say, for example, there's somebody out there that is, hey, I'm not exactly sure who I need to talk to, but is there a kind of a good start point for that?
Dr. Johnson, you have a little more insight in that?
Yeah, so I can kind of share how it's done at our clinic. And I mean, it differs, clinic by clinic based on the procedures that they have. But oftentimes when people are just getting started on a first line antidepressant or maybe a sleep medication, they often can go straight to their PCM and they'll prescribe it for them. Oftentimes, because we have people like Dr. Galvin that have this specialty knowledge and this experience, we want to make sure that we're reserving those people for individuals that may have very challenging cases. They failed many medication trials. They're not having a good outcome, or they have some significant contraindications with other medications that need that special eye that a psychiatric nurse practitioner would be kind of tuned into. And so oftentimes, people will get their medications from their PCM, but if they're having difficulty, or maybe if the PCMs are really overloaded and some of the people in, the mental health clinic, the prescribers have a little bit of space and time, they can come into the clinic and ask for a psychiatric consultation where they do an intake with a prescribing provider who then determines what that medication is that's attuned to their diagnosis and to what their presenting concerns are. Oftentimes they can stick with that provider if they're changing doses and they're going up or down, or they're switching medications. But if they end up stabilizing and doing really well on kind of one medication, sometimes they'll even route them back to their PCM and say, hey, you're good here. You don't need our level of care. We can actually have the PCM continue to prescribe that medication. Or they might say, hey, I want to keep you on because, there's some things that you're saying that are shifting, changing, your symptoms are up and down, and I want to make sure I'm monitoring you and making sure you have the right medication regimen. So I think, Dr. Galvin, they have that specialty expertise, that knowledge. And so we want to make sure we're using them in the right way. And so oftentimes they get the really unique and challenging cases, and the PCMs are a wonderful support to them as prescribing just kind of that first line antidepressant that someone might want to have and not necessarily need to come up to the specialty level.
Mhm. There's also embedded in the outpatient medical area, there's a BHOP provider who's a mental health provider, and he or she is a person that you can simply go in or call and make an appointment and say, I'm having a problem. I don't even know where to start. My aunt died last week, and my child left and, went away to college, and, my 5-year-old's acting out. My wife I'm not sure what's going on with her. But you walk in and they can direct you to whether it's family advocacy, whether it's the mental health clinic, whether it's the PCM, but they are just really a wealth, and they can do short-term counseling for about 4 visits at least, sometimes 6, to see if short-term counseling can help you through some of that. So they're not only to direct you, but to guide you through the first few weeks of the services that you're going to be seeking. And, while you're on that subject, I think the most important thing is ask somebody. If you're having a problem, I mean, call Family FC, call Airmen and Family Readiness, call the MFLAC, call the chaplain, call someone, call your primary care doctor and just say, I'm having a problem, don't know where to start. And within a couple of calls, you're going to be directed to the right place.
Yeah, and I think that's an interesting point there, right? And kind of what I can see with the different options, within this entire spectrum, going back to Captain Johnson, your one of the things that you talked about, that 2-minute rule, where maybe there's somebody that is in a situation where they don't know if it's, hey, do I need some medications? Is there something neurologically wrong, or am I just having some stressful situations, whether it be in the workplace or at home? And they, as far as your chart was concerned, right, that very hard task of running a marathon, somebody could be perceiving getting help as that far to the right. And so kind of, assisting them, to really, hey, this is the first place to start. Just asking for help, is a good first option, and maybe reaching out to at least somebody and kind of telling them what's going on, so we can get the right providers to differentiate, like, do we need the clinical psychologist, or maybe this is just a counseling piece? Does that kind of sound like a good place?
Yeah, I think that, the PCMs are always a good place to start. So, we do a lot of medical consultation with people from a lot of different specialties. And so they call us up, or they reach out to the clinic and say, hey, there's this patient I met with that has X, Y, and Z problem. Is that appropriate for mental health, or can I refer them over, or what's the appropriate pathway? So we have those conversations kind of behind closed doors, and people don't see. So if you go into see your PCM and you're saying, hey, I don't know what's going on with me, maybe you ask for a prescription for an antidepressant, but maybe you say, I don't know if I'm interested in this talk therapy stuff, or, how do I find that? If they have that provider sitting in PCBH, like Ms. Keys was saying, they'll walk them over directly after their appointment to talk with that provider. If that provider isn't available, they can always consult with mental health and say, hey, is this somebody appropriate to route to you? And then they can be present, to the clinic for an intake. So I think, there's always someone there. And if you feel less comfortable walking into mental health, if you feel less comfortable talking with a mental health provider straight out the gate, that entry point can really be that PCM, or even that other specialty provider that can then route that question that you have behind closed doors to us. And we can kind of welcome you on in, or, reach out to you, or make sure that you get something scheduled so you can come in and get the rest of your questions answered.
That's really good to know. And I guess this might be more of a MSC referral office question here, but for those of us that are in geographically separated units and not being treated by a military treatment facility for our healthcare needs, is it still possible to request support from a military treatment facility if we're on TRICARE Prime Remote?
There is the Military One Source that can help direct you to the appropriate facility, or tell you where the nearest facility is to your location. Your TRICARE office can also tell you who the civilian providers are that would be available to you.
Interesting. That's really good to know. Looks like we do have a question in the chat here, so we'll go ahead and get to this question. It looks like, what type or category of prescription medication could result in discharge?
Great question. There's a couple. I think I'm not at the liberty of discussing just yet, only because I've yet to PCS. So I have to be briefed more carefully about that. But yes, there are classes of medication that can disqualify you from service. I don't know if Captain Johnson does know some specifically.
So I think that there are specific medications that if you're on for a specific point of time, or if you have a certain status, are disqualifying for that status. So often a good example of that is sometimes we send people to a higher level of care. They do partial hospitalization program in a civilian environment, and then step down to maybe intensive outpatient where they're doing multiple times a day or multiple days a week at treatment. And they have their own prescribers over there that put them on medication. So we might have someone that's placed on, say, an antipsychotic or a mood stabilizer. And that is something that if they're on active duty and they're continuing to take once they return, it becomes a problem as far as them being able to continue serving in a specific career field or even being in the military. But it's one of those things where, they take it while they're there and we let them do the medication management. And when they come back and they transition back to the med group and we have our providers looking at their medication, they oftentimes can resolve that. I think it does become an issue if there's someone that absolutely needs to be on an antipsychotic long-term or a mood stabilizer or medications of that regard. And then that comes into question of, well, can they continue to utilize those medications and still stay in the military and still fulfill their duties? So that's definitely a question as far as the categories of medications. I also know that when we do certain, deployment clearances, PCS clearances, things of that nature, that if you're on certain amount of medications, or if you need medications to function effectively and without them you can't, that can create a challenge with regard to PCSing, or less so PCSing, but definitely deployment. So I think having a prescribing provider that can talk to that or asking those questions is very important. But oftentimes people are scared of being, on an antidepressant and that causing them to lose their career. And that oftentimes is never the case. So it really is just those medications that are aligned with specific diagnoses that are incompatible with military service, like bipolar disorder or schizophrenia.
Bipolar disorder.
Right. So those things would require medications that then are disqualifying, but it's really the underlying condition that is disqualifying for service.
I will also add to that, I think to the next question, do we discuss that with the members? Absolutely. One of the things that we do is trying to figure out ways in which we can address the patient symptomology without necessarily using any medication that can potentially affect the member's career. Like I mentioned before, let's say you have anxiety, there's definitely medication that's available to us that would not negatively impact the person's career. And so we try to make a plan around that. They do know when the patient is, where the member requires a medication that they have to be on and there's no choice, we also have to inform them about that. Meaning, let's say you're experiencing psychosis in the case of schizophrenia, well, you're gonna need an antipsychotic. There's no talk therapy that's gonna get you through that. We just have to do that. If it's something like depression, if it's something like anxiety, there's so many different things that we can try. Psychotherapy, lifestyle changes, mild medications that are not considered to be psychotropics. But we work that plan out depending on the member's situation and also depending on the severity of the symptoms. It's very unique to each individual.
Got it. That's great. And again, it kind of, I'm seeing a theme, I believe, with everybody that's spoken today, that, as long as we're kind of being a little bit more active in reaching out for support, there could be, some things going on that, if untreated, could be worse than just getting treated. And even if the medication could be disqualifying in the long term, maybe in the short term, if it's addressed in a timely manner, we're active about getting assistance. Okay, well, yes, it's disqualifying, but we've treated the issue and we can kind of lower the level of care to get that individual not only right mentally, but also back into the fight. So they can continue serving as a uniformed service member. Does that sound about a good way to summarize that?
That was brilliant.
And so reading,
also,
we do. Oh, go ahead, Dr. Ms. Keith. Mm-hmm.
I just wanted to, I hate to use the term foot stomp because it's so overused, but just to emphasize, medication is not the first resort when someone asks for help. Most disciplines are going to try behavioral ways of coping and helping the person to figure out what actually is the problem is the first step. But there are so many things that happen, whether with the provider or between the provider and maybe command assistants or various resources that do not include medication. So I want the viewers to know that if they walk in the door, no one is going to slap them on medication and then ask questions later. And I know the providers where I work in the mental health field, they are really going to sit down before they give a medication, and they're going to make sure that the person knows whether it's one that could affect their career. They're also going to look at other options because there are so many different options for them, except in those couple of things that were just mentioned. I'll be quiet
That
now.
is really, really good information. And we're going to back up. We did get a question. We might have skipped over it, but the question, and I'll read it. I was informed by TRICARE that members who are not near a base, which oftentimes recruiters are part of a geographically separated unit, a referral is not needed, but you just find a mental health provider that accepts TRICARE. Can anybody speak to the legitimacy of that? Or is that a little bit more of a referral office?
No, I was a TRICARE provider for 17 years. And in the area of mental health, a person can walk in or call in, and as long as we accept TRICARE, then it's an automatic. It may be up to 12 sessions now. When I first started, it was like 8 to 12 sessions. And then when you get to the end of 12 sessions, you simply go back through TRICARE and request more sessions. So it does not have to be either a TRICARE referral or a primary care doc referral. They can go directly to the mental health clinic.
That is so summarizing that, if somebody is geographically separated, they can essentially reach out directly to a counseling agency or some type of a facility that specializes in that regard directly, and they can essentially count on that those treatments already being approved.
Right. Now, if it was me, and I've done this, even though I know that, I would still call TRICARE and say, I just booked an appointment at Jones Psychiatric Clinic, or, Theodore's Mental Health Center, and they say they're TRICARE providers. Can you verify that? And usually they'll send you a list of providers in your area. So I would always want to go back and see what the current rules are, but that's what it was when I was in practice.
I'm sorry that I have to leave you guys a little bit early. I don't know if anything else on my end that I can do right before I leave. I have a couple other engagements that I have to attend to.
No problem, doctor. We really appreciate you showing up, sir. Thank you so much.
Thank you, Dr.
Thank you so
Galvin.
much. Thank you so much, everybody. And I wish everybody the best. I genuinely mean when I say this, please do it early. Urge your airmen and airwomen to do it early. Thank you so much for having me.
Thank you.
Thank you.
Bye.
Yeah, one thing I would like to add about that, I'm not super familiar with people that are kind of geo-separated from, or, the recruiters and how they, manage their healthcare. What I can speak to is, in the mental health clinic, when people, we're all active, for people that are active duty, there's always a component of readiness when it comes to mental health. And so if that individual is seeking care with a mental health provider and they're seeing things that impact readiness, but we don't know about them, then we're not able to assess, is this member deployable? Can they go to TDY? Can they PCS? Can they do the mission? So anytime you're at a clinic that does those off-base referrals and they're receiving care in the community, we're getting updates from those providers. We're knowing what the diagnosis is, what their treatment plan is, what medications they might be prescribed, things of that nature, because we're, there to track readiness and their ability to be on mission. So when you talk about going into the civilian world and receiving care through TRICARE and things of that nature, I know that that's definitely a possibility and that members are referred off base. to see civilian providers all the time, but we are tracking those people. And so it is a requirement for us that whenever someone's seeking care off base with a civilian provider and they're active duty, that in the mental health clinic, we know that and we're tracking that and we're getting regular updates from their providers. So I wanted to put that out there because just being like, oh yeah, like I'm dealing with these struggles and I just started seeing a provider, and then you're, the people that are responsible for your mental health care or medical readiness are unaware. I've seen how that's created issues when people come back to the clinic and they have a diagnosis that, or we find out that they've been seeing someone off base and they haven't been meeting the readiness standards, but we weren't knowledgeable about that. That can have a negative impact. And so I would say, even if you're not necessarily receiving care from the mental health providers in the station or in the base that's closest to you, there's some importance there of them being aware or tracking that, or at least being knowledgeable that you're seeking care outside of the med group.
Really good to know. Thank you for sharing that piece of it. And I'm going to read the next question here. And it looks like I had a couple new individuals pop in. And one thing I did want to note as far as the intention of this briefing as well is not only, to make sure that we're taking care of ourselves, but also, taking care of subordinates, peers, and those to our left and our right. So, as we're taking some notes of a lot of the things that are being discussed, I'm personally taking some notes on, if I interact with somebody, whether it be, inside or outside of the uniform, these are going to be really good things to know how to handle somebody that might be going through a rough time. And so the next question here was, I guess, part 2 of the first part about the medication that could result in discharge. Can you talk about medications or categories of medications that individuals can take that do not result in discharge? So I guess maybe some medications that are more safe or compatible with continuing serving if somebody maybe was going through a rough time and wanted to get help, to treat something, but they still have a desire to serve and they don't want it impacting their career.
Yeah, SSRIs, SNRIs, which are your standard antidepressant that also have anti-anxiety properties. Those are pretty standard, like I said, can be prescribed by PCM and are pretty, not impactful. A lot of people are utilizing them and doing just fine. When it comes to, I can't speak, I'm not a prescribing provider, but I know when it comes to benzodiazepines, when I see patients that are on those and I'm attempting to do work surrounding, say, anxiety, there's a lot of kind of research to support that there's that contraindication between someone having a benzodiazepine and also trying to pursue, say, an exposure or psychotherapy that focuses on anxiety. And so I think that's the really important collaboration piece between myself as a psychologist and a prescribing provider, is to say, hey, let's get on the same page. Would you be open to maybe switching them off of that medication and maybe onto an antidepressant, so that they can continue to get the medication benefits, but they're also able to do the work that I'm doing with them and be effective at that work. So I think that collaborative piece is really important. And then there are quite a few of medications when it comes to sleep medications, other medications that have anti-anxiety properties that are fairly commonly used. So there's a whole set of different classes of medications that can be utilized, and a prescribing provider could probably speak to that more, but it's often only, usually the antipsychotics and mood stabilizers that start to present some concerns. And so that would be, those are the ones to necessarily, steer clear of. And then there's a whole other broad toolkit, like Dr. Galvin was saying, of medications that can be utilized, and even ones that, have off-label uses for mental health concerns.
Very good to know. Senator Perez, you want to read some of the next questions there, sir? I think we got a couple more in the chat.
Let's see here, that second question, the third question was, are members thoroughly briefed on the impact certain medications could have on their career prior to being prescribed?
Yeah, I'm pretty sure they touched on that a lot.
Yup. So is there any way we can do a panel like this regularly to get the word out so people aren't so intimidated or scared to get help? Yeah, I mean, I believe this is something we can definitely do more regularly. I think Sergeant Nixon touched on that in the chat a little bit, but just for everybody in the Zoom world, I mean, I know next month, I believe, the 5-6 will be having a new executive council. So hopefully in the near future, maybe this could be something that could be done more regularly, quarterly maybe. Because I mean, especially as recruiters, anybody in the Air Force, military, I mean, but just especially recruiters, just us being all geographically separated, I think this is something that is extremely helpful. I mean, I know for me, just listening to all of this has been extremely helpful, very informative. So, I mean, for us to be able to do this more often, absolutely, I think we should be able to do it. I think we can coordinate that with the next executive council that'll be in charge, I believe, starting next month. So, yeah, I'm definitely good with that, sir. Let's see. I believe that's all the questions in the chat. Does anybody have any other questions?
Or even maybe some scenarios that you know, somebody that is close to you or that you love, or you personally, or a hypothetical scenario of, you know, a situation that somebody is in or was in or might be in, that we can kind of take advantage of having these awesome providers here to share some awesome pieces of information.
Did you want those to come from the audience, or did you want them to come from some of us?
We can always take questions from Mrs. Keith. Those are my favorite.
I had a scenario,
Mhm.
which was really, really neat. I mentioned I worked in a psychiatric unit years ago, and I worked with adolescents and children. And there was this darling little girl in the psychiatric unit. And shortly thereafter, her older sister was in the psychiatric unit. They both had manic depressive disorder, which is bipolar disorder. And kids in their manic phases can destroy property. I mean, it can be a mess. Well, the parents, who had always been afraid to seek help because they're afraid of impact to the career or whatever, came into our civilian hospital for family therapy. And I started seeing them afterwards, after they got out of the hospital. And so we're in my office, and now I'm seeing the mom for depression, the two girls for their bipolar disorder. And Dad calls me one day and he said, "Miss Keith, I'm an active duty member, and so I'm not really, I don't have TRICARE benefits. What would it take for me to be allowed to come in to see you?" And I said, "Well, your TRICARE is covering 3 of your family members. How about let's just call that, a family session, and you come in and we won't worry about charging you. I will just, attach you to whichever child or your wife, that is there with you." So we eventually worked on the whole family. This was a situation where the house was constantly in mayhem. Dad was a wreck. Did I mention he was the vice wing commander? Vice wing commander of the base. He couldn't have people over. There was so much shame, between the wife being too depressed to do anything, the kids being out of control most of the time, and Dad really didn't want to go home. I worked with him on self-care. No matter what, at the end of the day, stop and go for at least a 30-minute walk or go to the gym. But I've got to get home and take care. No, you stop and take care of yourself first. Anyway, as it played out, it was just really, really neat to see the parents realizing that their family was just one of many families, maybe could influence other Air Force families. The wife started having me come to visit her wives club meetings and talk about mental health in the family. And at the Dad's retirement ceremony, he introduced me as his shrink. And I treasure that. I really treasure that. And the worry about impact on career isn't just true for young airmen starting out, but it was true for this family all the way through their career.
Well, it sounds like that ended in a positive note. So whatever you did as a shrink, it sounds like it was very successful. And then that piece of taking care of self, I think, is something that, everybody can utilize, whether you're going through something or not, because, life in the Air Force, and especially in recruiting, it tends to take its toll. And, taking a moment to take care of yourself is, definitely something I try to do, for sure.
Yeah.
All right, let's see. We do got another question here. Oh, let's see. Nope. All right. Well, yeah, let me see. I did take some other notes, and it was very enlightening, Captain Johnson, to kind of hear a lot of your approach to this, which was what I appreciated, a very, very active approach to this. So are there any, additional healthy habits that you would, suggest for that habit stacking, maybe kind of transitioning from the, brushing your teeth and push-ups to maybe something that, an organization that is comprised of, approximately, 3,500 recruiters who on a day-to-day basis, have to interact with members of the community and go out to schools, and a lot of those settings that we are all in requires us to have throughout the day a lot of different conversations with a lot of different individuals. We're getting pulled all over the place in terms of where we're at mentally. In 1 minute, we're talking about basic military training or officer training school, and the next, I know for myself, I'll go from one conversation in a 10-minute period talking about the world of clinical psychology and what it's like, for an APIC match, and going from that into licensed clinical social work to the next minute trying to talk to a rated candidate. But any type of habit stacking that you might be able to share with us for the recruiting field?
Yeah, I mean, I think more broadly, building healthy habits, it's something that I brief on a lot. And the big challenge is oftentimes if you ask a 6-year-old, what's a healthy food, they can give that to you. If you ask somebody on this call, who's worked out in the past month or year, like, yeah, of course. But the reason that health and those things that you do is mostly about habits is because we oftentimes have difficulties getting us to do those things, not only the first and second time, but the 50th time, right? Again and again and again. And so I think with recruiters, I've treated a few, and they talk a lot about the pressure of the job, the expectations, what you just talked about just right there, the switching of attention and concentration and the many things to do in different areas and how overwhelming that can be. And so when I think about healthy habits and, habit stacking and all the things that I suggested, I think the important piece of that is how do you get started and then how do you maintain that? So if you're talking about, going out and you're on the road a lot and then you're back at home and then you're doing this and that, like, what are the ways that you can have some consistency with the behaviors that you're starting to build? And so I think habit stacking in and of itself is a tool that can be beneficial because you can take it with you, because you're going to brush your teeth in a hotel room the same as you do at your house. And you don't have to do it with necessarily just exercise, right? So, every time I talk to 10 candidates, I take 5 minutes on my own to do some deep breathing or some mindful breathing. Or every time that I, get somebody else in that, I might have slipped away, but I actually got them and they're actually on the recruiting pipeline and they're doing well. Okay, how do I want to reward myself for that? That's the temptation bundling, adding that reward so that every win that you have feels pleasurable. It doesn't all feel like just work and stress. There is a reward at the end that's meaningful to you. And there are habits that you're continuing to build and to have persist because you're creating that maintenance through habits that you already have. So I think one of the biggest pieces is how do you make it easy for you, for yourself? Habit stacking makes it easy. How do you get started on a really big goal? That 2-minute rule that I talked about, that's, starts you off easy and then progresses to getting harder. It's, how you shape your environment. Environmental cues are huge. fixing and changing your environment to create those habits and making it easier for yourself is also really important. So there's really like a whole plethora or toolkit of ways to build healthy habits and how to encourage maintenance of those habits. That's like a whole other brief. But I think starting with the habit stacking plus the temptation bundling and the 2-minute rule can be some really precise tools and strategies that you can utilize, and then just make it, relevant for you. What might be working for habit stacking for someone else is not your habit stack. So find that habit that you already have that is really salient or occurs, every day for you, and stack on top of that.
Right on.
Now, do you come with a menu of like, hey, these are the, 20 most important habits that you can have or something for somebody that might be in that situation where, the overwhelmingness of the mission is just, a little too much, and maybe we can get in front of that and be active and say, hey, like, or maybe even like some material or a book that really does kind of share those specific
Absolutely. So those 3 books that I had in that last slide, I hope that you're able to share that PowerPoint. Atomic Habits by James Clear, that's the one where I tell people start there, because it's a very easy read, and it has some of those tips and strategies and explains the ways, the pitfalls of when we're trying to form habits, what gets in the way, what makes it difficult to do so, and what are some tips to making it easier. But also those other ones, Tiny Habits by BJ Fogg, and then also the other one that I have on there. Those are really valuable books as well, because they're all providing a lot of that same information about how our brain works, how we work, why it's difficult to build habits, and what are the tips and tricks to getting us there. And so I think if you have an interest in building habits and creating healthy ones and maintaining it, which is the most key important part, then starting with those 3 books can be really beneficial.
Awesome. Well, that's very good information.
Thank you so much, Captain Johnson. Absolutely. Is there any more you wanted to ask right now, Shay?
No, I didn't really. Time got away from us. It sure did. Yeah, because we're 3:30 Eastern here. So, I think we got a lot of good content, and we're going to get back with our 5-6 organization. Hopefully, get a little bit of feedback from the field on how this went, and we might just see if we can't pick this thing up once a quarter or something to that effect, and we'll start with like you said, just that next step, which might be just getting the next one on the books, and just go from there and kind of see if this is something that's going to have a positive impact on the recruiting career field. So
Absolutely.
yeah, thank you guys so much. I'm going to pass it over to Sergeant Perez Santiago. You want to bring it home, sir?
Yes, sir. Definitely very informative. Thank you so much, Ms. Keith, Captain Johnson, Captain Galvin, who I know how to leave it a little bit earlier, but thank you so much for all of this. Again, very informative, very helpful. It's being recorded, so we're definitely going to get this out to the field. We also have some contact information, some resources like psychologytoday.com, veterantraining.va.gov, Military One Source, which I know is a very common one, and veteranscrisisline.net. It's in the chat, but we're also going to get that information out to the field, so everybody can have that information on what websites, what resources to utilize. And also, we're going to have some information nationwide, just some contact info for all the MFLAG locations and phone numbers, just according to what duty station you're closest to or at. So yeah, that pretty much concludes the mental health panel. Tech Sergeant Nixon, do you have anything else to add, sir?
Copy. Yeah, man, just want to say thank you. Thank you again to our providers for being on. This was very impactful. I've been over here jotting stuff down, so thank you guys very, very, very much. I see we have Chief Goldstrom on here. Sorry to put you on the spot, but I just wanted to ask if you want to add anything before we close out here.
Hey, thanks so much, Sergeant Nixon and teammates that are on the call. It's always great to see you guys. To our provider, well, let me back up. So my apologies. I'm currently traveling. I'm sitting in the Centurion Lounge here in DFW. So sorry for the background noise. So I'll keep my comments short. To our providers, thanks so much for pouring into our recruiters in the 5-6 organization within Air Force Recruiting Service. I'll tell you, I'm so proud of what the AFRS 5-6 are doing. You talk about leaders in motion, leaders that care about their peers and care about what this organization is about, but also the wellness of each other. That's what this organization is. Also to the providers, the command is very much aware. I've shared my mental health journey very openly. I was exposed to combat stress on my last deployment from 2019 to 2020. As a result of that, sought assistance through BHOP, and then ultimately a 12-session CBT program. Graduated from that, was diagnosed with specified trauma and stress disorder. And the one thing I learned from my treatment was I'll never be the guy again that deployed in August of 2019, but the guy that returned in July of 2020 will be the best version of that person that I can be. And that's what that treatment taught me. And it also taught me that it's okay to be happy. So with that, thank you so much for pouring into our team. To the 5-6, I just continue to be amazed and proud of what you guys are doing. And thank you so much for letting me jump on here for just a few minutes.
Thank you, Chief. Travel, sir. Would anyone else like to unmute and add anything else before I continue closing out here? Cool.
I'm good to go, sir.
Cool. Copy that.
Appreciate you.
So, yeah, no, thank you. Thank you. And Sergeant Perez Santiago for moderating this thing. Thank you to the organizers once again for making this happen. Just a quick note, we have elections that are coming up soon. You'll see an email come out from me. So pay attention to that. At the latest, it'll come out Monday, but it'll have all of the instructions for how you can throw your name into the hat if you want to go out or be voted by the command for a council position. So as you guys can see and as you hear from Chief, you know what we're about. And we're all about working together to make a positive impact. So if you have ideas for change, if you really feel as though you can dedicate that time to something like this at this level, then put your name in the hat. And even if that's not the case, if you're going to remain a member, I mean, you can ask Sergeant O'Shea. He and I talk about it all the time. You don't have to be in a council position. We're just looking for people who have that desire to, once again, hey, how can I make an impact, whether it's within my flight, my squadron, group, command, whatever it may be. So just be thinking about that. But again, to Ms. Keefe, Captain Johnson, Captain Galvin, thank you for being a part of this with us. And that's all I have, unless any of my council mates want to add anything. Thank you very much. And that will conclude today's meeting. Y'all have a good one.
Thank you.